Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. I am going to introduce Rachelle Mallik. Rachelle is a registered dietitian and owner of The Food Therapist, a virtual practice specializing in nutrition counseling for reproductive health. She primarily works with clients who are trying to conceive, pregnant, postpartum, or lactating, as well as those with reproductive conditions such as PCOS, endometriosis, and hypothalamic amenorrhea. Rachelle supports her clients with a weight-inclusive, evidence-informed approach that focuses on health-promoting behaviors and nourishment over restriction. Rachelle started working in reproductive health over 15 years ago and is a mother to 2 young children. She has presented at various events in Chicago and nationally to educate the community as well as fellow healthcare providers on nutrition for reproductive health. This includes being a panel speaker at the American Society of Reproductive Medicine with Anne.
Panel, exactly.
In 2020. She also serves as a content expert at the Academy of Nutrition and Dietetics Nutrition Care Manual. Cool.
Awesome. I know. I was thinking the other day how I also listened to the podcast Smartless and how it's basically them just being like, hey, we're famous and know lots of famous people. What if we talk to them? That's kind of like what we're doing in the world of reproductive medicine. We're like,
for sure.
Who are the people that we have enjoyed talking to and that we like to talk about this kind of stuff with? And that's who Rachelle is. I had so much fun getting to meet and present with you. And I'm just so happy that you're here to talk with us today.
It was such a joy to do that. And it's awesome to be here almost 2 years later. I mean, we met over 2 years ago, height of the pandemic, doing a virtual conference.
And it's so hard to actually meet people on virtual conferences too, because usually, you're at the actual conference and you sit at tables together at lunchtime and kind of get to know what everybody's doing around the country.
Honestly, I think we got to know each other better because of it, because you're right. Normally when you're showing up, everyone just submits their slides in advance and that's that. But we had to get together to record it in advance and then also be there together live the day it was broadcast to answer questions. And we actually did more Zoom planning meetings because we were all like, this is our first time doing a virtual conference. And so I think we actually got to know each other more than other times that I presented where it's just like an email or two and then you wave to each other and you talk and then you go your separate ways. So it was actually kind of a cool experience.
Right. Not great for meeting other attendees, but we definitely had lots of preparing for the presentation.
Very cool. All right. Anne, where would you like to start on this one? I'll let you talk some.
Well, I think I'd like to start by just, what are the things that people ask you, the things that you get asked over and over again that you spend a lot of your visit time myth busting? What are some of the common things you want to make sure we get the word out for listeners?
The things that honestly I get asked the most about are gluten and dairy. And this is not just for PCOS, but for all types of fertility challenges. And it's something that I'm constantly trying to stay updated in literature. If there's anything new I should know about that I'm missing. But in my understanding, neither of those across the board is harmful. And then I can talk about why certain people may want to avoid them depending on their unique situation.
Where did this come from? Was there some person or some study or where did this first start that everybody decided that they had to go gluten-free or they had to cut out dairy?
I don't really know the origin of it. The one with gluten, I can think about celiac disease, right? Because if I do have a patient or a client with repeat pregnancy loss who hasn't been screened for celiac disease before, I'll often ask about that or dig into a little bit further because there can be a link between those two. But that's very rare. And celiac disease affects about 1% of the population, I believe. So it's still exceedingly rare, but that would be a case where I might look into it. In my experience, I'm also trained on the use of the Low Fodmap Diet. I don't know if you've heard about that. It's kind of extraneous to the fertility chat, but it does come up a lot in my work, both for fertility clients and my GI clients. It's that certain compounds within wheat and dairy can be difficult to digest and lead to gas and bloating, not necessarily causing inflammation, but just doesn't feel so good in the gut. So when people remove those, if they are sensitive to the FODMAPs or the fructans or the lactose in those foods, then that can contribute to some of those symptoms they might be experiencing. Again, that's not necessarily affecting fertility, if that makes sense. I can, again, going to go further into this. So yeah, gluten and dairy across the board do not need to be avoided if somebody's dealing with infertility, even unexplained infertility. I think that can be really difficult, right? When someone's dealing with unexplained infertility, they're trying to look for anything and everything. But I find the issue with that is, especially if those are foods that they like to eat, then all of a sudden 2 large groups of foods are removed from their diet that can provide a lot of nutrients as well. And you can certainly eat a well-balanced diet without those, but it's kind of this idea of, I mentioned it in my bio, I come from a place of abundance rather than restriction, and really limiting the diet only so much as you really need to support your health, right? Whether it's reducing bloating because you don't feel really well, or just like actually damaging your gut in the case of like celiac disease.
I follow a whole food plant-based vegan diet. A lot of times, like when people are ordering food at work or like asking about my dietary restrictions, oftentimes they're like, oh, you're gluten-free, right? I'm like, no, give me all the gluten.
You don't need another layer on top of that, right?
Right. I'm like, please give me all the gluten.
Yeah.
There was an episode of, I can't remember which cooking show it was, but it was like they had the celebrity challenge. I think it was for Zoe Deschanel, and they had to pick this whole like buffet dinner, and she was vegan and gluten free. I mean, it was all this stuff, and you just saw all these professional chefs being like, but what am I going to feed her?
Was it like flax crackers?
Is she raw vegan too?
And the person who got kicked out, it was because they bought ice cream at a store because they wanted to get a non-dairy, and they're like, what kind of chef wouldn't make their own? And like, I don't know how to make a good dairy-free, like gluten-free. They got kicked out because that was not okay to use a store-bought part of their dessert. So, but it's a challenge. And when you have people coming to you, are they usually coming to you to ask a question, or are they coming to you because they've already cut out all this stuff and then you're having to like talk with them about how maybe they didn't have to do that?
Definitely both. In a first session, we can talk about how I approach clients and how I work with clients, but I'm really trying to gather as much health history, diet history, medical history, dieting history, and current dietary habits, so I understand like what food preferences they have, right? If they do have certain dietary restrictions, like they have to do a low Fodmap diet for their IBS, or they're gluten-free because they have celiac disease, or they're vegan for ethical reasons, or maybe some dietary things that are there already. But then there's also that I was told I need to avoid XYZ, or I read that I need to XYZ. Is that true? So I do see both. I had a client just earlier today who is gluten and dairy-free with PCOS. And we were talking through like, how does that work for her diet? And we were talking about like some snack ideas around like giving some carbs with fat and protein. So I suggested you could do hummus, you could do a nut butter, you could do some like cheddar cheese. And then she's like, is cheese okay? And so I talked about, I don't know how much we want to get into the higher fat, low glycemic index dairy products that are, better in the research for PCOS than say like skim milk would be, and having like 1 serving or less a day should be totally fine if that's something they want to include in their diet. If they don't miss it, if it's not usually part of their diet, no big deal. But if it's something they've cut out and was an easy source of protein and fat for them and calcium as well, then we look at like, do you really need to do that? Is that serving you?
Are people usually pretty receptive to that advice, or is it really hard for people to let go of like something when they've already been following a more restrictive plan?
In my experience, most people are open to wanting more foods to choose from, right? To liberalize the diet a bit, to make it less restrictive, to make it less stressful, right? Because infertility is already full of stressors, especially fertility treatments and infertility. So my approach is like use nutrition as a support tool. That's what our whole ASRM presentation was about, was like support tools for fertility patients. And I like to think of nutrition as a support tool rather than another checklist, another thing on the to-do list that you're doing wrong. I say most people are receptive, not everyone, but I'm really about informed consent and educating, and then the patient deciding what works best for them. So really trying to tease out the data that we do have available, knowing the limitations of research studies, especially nutrition research studies, but really what again feels good for them and seems to make sense given informed choice.
Yeah, with my wellness patients, when I'm counseling them about nutrition, I like to say my approach to nutrition is about nourishing your body. It's not about taking anything away. It's about choosing foods that are going to, promote wellness and nourish your body. Diet is a true 4-letter word.
Mm-hmm. Yep.
Rachel, how did you even get into this field? What got you interested in nutrition? And then how did you end up really focusing more on the fertility side?
I'm not like second career, but I'm kind of had a little bit of a windy path to dietetics. So I was a pre-med undergrad, and you can't get a degree in pre-med, right? You need to have a bachelor's in something. A classmate had turned me on to nutrition. She's like, the classes overlap a lot with the pre-med program in terms of chemistry, anatomy and physiology, biochemistry. Like there's a lot of sciences in nutrition. And then I also had to take like macronutrient metabolism, micronutrient metabolism, which made chemistry a lot more accessible to me. It made a lot more sense in those forms. So I graduated with a degree in nutrition, a bachelor's degree with honors in nutrition, and was pre-med. And had taken the MCAT and was just figuring out next steps. And I was like, I really want to get some more experience in the medical world. So I moved back to New York, where I'm from, and I was looking for jobs in New York City and got a position as a patient coordinator at the Weill Cornell Center for Reproductive Medicine on the Upper East Side.
That's how you ended up there.
That's how I ended up there. And a patient coordinator role was really unique. It was really interesting. Actually, I was just talking to another patient about that who isn't going through fertility treatments and has some questions about it. And she's like, you worked in the fertility clinic for a long time. Like, can you tell me like what's involved, what to expect? So I worked there for about 5 years. So I was there from 2006 to 2011. And in that time, just was started thinking about like, how does nutrition play a role in this? It really wasn't talked about that much then. It certainly wasn't talked about by any of the doctors that I was coordinator for. Anyway, I was starting to say about why it was an interesting position. It was like basically patients would be told, okay, IVF is your next step. Go talk to Rachel and she'll walk you through everything. Right. So I was like, just telling them, like, we talked through their menstrual cycle, like if they had regular periods, when do you get them? And like, here's when you'll start stimulation or OCPs, oral contraceptive for suppression before a cycle. So I'd walk them through all of that, and just kind of give them any tips that were relevant or needed to be explained. Like I was coordinating care between the doctor and the patient, basically.
Did you tell them anything about nutrition? Did they ever ask you, or was it just like a hidden part of your background that like they were?
The question is always like, what else can I do?
Yeah.
Is there anything else I should be doing?
Yeah. And at the time, I knew nutrition from my bachelor's degree, right? The classes I had taken, but I wasn't yet a dietitian. Not that I couldn't provide some nutrition guidance, but it wasn't really front and center how nutrition will play a role explicitly in fertility, right? That wasn't something I was trained on in undergrad. I don't remember that being talked about. Prenatal nutrition, definitely, postpartum or lactation, but not fertility. So it was kind of just like, people are wanting to know what they can do, right? Because you can feel really out of control when you're dealing with the IVF and infertility. And so it just got my wheels turning. So I went back to school at NYU and I kept working full time. I went to school 3 nights a week. So it was busy. And then, from there, I just did my training to become a dietitian. And then long road, I ended up in Australia with my husband. I shared on social media the other day, I celebrated 10 years as a dietitian, 2012, July 18th, 2012, I passed my RD exam. So it's exactly 10 years ago. So I've had somewhat of a windy path since then. So we'll flash forward a bit past the Australia piece and working clinical full-time in Chicago when we moved back to the States. And then my son was born September 2016. And I left that full-time clinical role and was really wanting, though, to still stay in working, but trying to balance parenthood, motherhood, and childcare. And was like, you know what? I've worked in this space for a long time. In the interim of my other years of experience as a dietitian, I did work with clients who are going through fertility treatments and pregnancy and postpartum. What I was realizing at that time when I was trying to figure out next steps was like, there aren't any dietitians that I'm seeing, definitely not in the Chicago area, that are specializing in reproductive health. And also that have the training that I do, having worked in a fertility clinic for 5 years.
Well, that makes you such a great resource, because other people, even if they have worked with other fertility patients, it's still not quite the same as knowing the ins and outs of it as well as you do, in terms of like what parts of the cycle are they going to be feeling different things in terms of their gut and progesterone exposure and all that stuff. So that's great. I didn't know that you had that much clinical experience on that infertility side as well.
I feel like this is getting really long. Brevity is not my strong suit.
No.
You'll fit right in.
But the Australia stuff is interesting too, because that means you have a bit of an international perspective, because so many things that we talk about when we're trying to talk about nutrition and lifestyle is our challenges in America with everything being so processed and fast food. And so I'm curious to hear what that was like for you too.
And we do have a fair amount of Australian listeners too.
That's true. Nice. We do. Yeah, we have more Australian listeners than Canadians. Isn't that crazy?
That's amazing.
So shout out to Australia.
You think it's because you're on the West Coast? It's like you're just that much closer than...
But we can drive to Canada.
Right, I know. Canada is definitely closer than Australia, but people can get to Vancouver easier than New York, I guess, more easily than New York.
Vancouver is like our sister city. It just blows my mind.
Yeah.
Come on, Canadians.
But we support Australia.
Yeah, great to hear there's Aussies listening. I lived in Melbourne, Australia for a year and a half, and then Sydney for about 6 months. And it was a great experience. The challenge was that they have a different license for dietitians there, and they don't do mutual recognition. They're called APDs and we're RDs. But I still was able to get some experience in the nutrition field there. And honestly, they deal with the same troubles we do. The diet, the food is fantastic in Australia. The coffee seems amazing, but the challenges are pretty similar regarding like lifestyle and modern foods and
there probably is some significant overlap for Western countries.
Yeah, but otherwise it was a fantastic experience. Always happy to chat about Australia any other time. So then I was saying that my son, when he was born in 2016, when he was about 5 months old, I started my LLC, which is the food therapist. So I'm based in the Chicago area, but it started as a telehealth practice and it has remained a telehealth practice because it is very flexible and it's a lot easier for my clients to see me. They don't have to travel. Depending on state licensure, they can be anywhere in Illinois or different states. So it makes that a lot more accessible. And then it's just, especially folks who are going through fertility treatments that are already in clinics all the time. It's just like one less appointment to have to travel to, or like acupuncture. Like there's a lot of things that can't be done virtually. So it's nice that my services can be offered virtually.
So maybe walk us through, like when someone does just find you out of the blue, you're not getting a referral, you don't even know what they're working on. Like, how do you start having the conversation? Do you have them take a detailed food diary? Like what's your kind of new patient approach?
So a lot of my clients will have an intro call, like a discovery call where they're just kind of seeing if we're a good fit for each other. But some people do just like go right ahead and book the initial consultation and assessment where we're actually like a paid session, we're digging into everything, we're getting goal setting. But the intro call for some people does help figure out like, are we a good fit for working together, especially with my weight inclusive approach, which we can talk about a little bit later, or just like what their needs are, what they're looking for, the type of dietitian that I am, like practicing from a non-diet approach where we're like really informed by intuitive eating and health at every size. Some people really want very specific rules.
They want you to just send them like the diet that they follow.
Yeah, like where's my meal plan? And like nutrition isn't really that black and white. And I really want to meet people where they are and what their, again, I was talking about before, their history, their diet and their dieting history, their dietary preferences, their lifestyle, who's doing the cooking, the meal planning, the shopping, all those things. So really, I'm just trying to understand that person and their situation as best I can. I think one of the challenges when somebody finds me versus a referral is I may not have some of the the soap notes or what have you from the doctors.
Right.
So I'm really going off of what they understand their challenges to be or their diagnosis to be. And then I'll usually try to either have them upload their labs or reports and such, or reach out to their doctor and have them fax. I still have an e-fax for that very reason. Some folks will just come to me because they want to do everything they can to support their chances of conceiving and having a healthy pregnancy. We know that nutrition can play a big role in that first 1,000 days. That is very well studied, right from conception through the first 2 years of life. So I think it's just a natural extension that preconception health matters too, because you're getting into a position for a healthier pregnancy. And then we also have data on the role that nutrition specifically plays in ART, and assisted reproductive technology. Anyway, so my point is that some folks are just trying to optimize their chances, and I'm doing a dietary assessment. A lot of people, maybe they're not eating enough and we're just working on that. Maybe they're skipping meals, or their diet's low in whole grains or low in fish and seafood, or things that they may want to include in their diet that they're not currently for whatever reason, and that the data has shown that may support their chances. And so we'll talk about those kind of things. And then if they have a condition like HA or PCOS or endometriosis, we might be looking at some other things as well.
In terms of lab work, is there anything specific you like to look at for new patients in terms of labs?
Yeah, that's a great question. So I do like, if they have 2-day free blood work, I do like to see that. AMH levels if they have it, AFC levels if they have it, just so I have a clinical picture. And then for nutrition specific things, I'm usually asking for fasting glucose, A1C, thyroid labs, especially like if they have thyroid antibodies, more elevated TSH, hemoglobin hematocrit if they have any anemia that's showing up, vitamin D, because everybody's low in vitamin D, it seems.
Yeah, especially here.
Those are probably the big ones. Am I missing anything? Those are the things that I'm generally looking out for, because people don't often have that many other nutrient labs. And some net labs are hard, like iodine. We don't have like a great biomarker of someone's iodine status. So, a lot of things we're looking at their overall dietary intake to assess if they're meeting the estimated needs.
So maybe talk a little bit more about what you mean by saying you take kind of a non-diet approach. So how do you explain that? Because you're right, it's not like most people come to you fresh, having never thought about a diet before, right? Like most people, they've probably gone lots of up and down and tried things. And like the fact that they're now finally wanting to do a consult, there's probably a lot of emotional baggage there. So like, how do you start that conversation, and what do you think makes your approach a little bit different?
So, Ruby was already saying that like diet is the 4-letter word. There's a difference between a way of eating, which is the traditional definition of diet, and diet, which we know colloquially now is pretty much I'm on a diet, right? I'm trying to lose weight. We're more in a wellness culture in the aughts and the 2010s and going into the 2020s, where people aren't necessarily like saying that they're trying to lose weight, but they're just trying to be healthier. But usually that's often code word for losing weight too. So a non-diet approach is helping put in diet interventions and behavior change that can support health. We might be increasing their fiber intake or their protein intake or their carbohydrate. Like we might be looking at foods that include those and trying to shift those in the diet a bit or work towards dietary patterns that have been associated with improved IVF outcomes. But we're not just trying to change the diet with the intention of weight loss. I think that's the big difference between like a weight centric, a weight normative approach and a weight inclusive non-diet approach.
And is that hard for some patients? Do they come to you because they're like, no, but I was told I need to lose 5% of my weight to start ovulating?
Yeah.
Like, do you have to kind of dial people back from ideas that the goal needs to be weight loss? I think we're probably going to make that our short stack for this episode, but just, I mean, is that something that's usually a conversation when you're having referrals?
Yeah. I mean, it depends a lot on the patient's history and why they were referred. Plenty of clients that I have that weight loss is not on their radar and they're just wanting to support their nutrition for fertility. I tell them about the non-diet approach, what that means, how intuitive eating or some of the health at every size principles may inform our work and the type of nutrition interventions, like how we do the nutrition interventions. But then people who, especially those who are in larger bodies who have told that they need to lose weight in order to proceed with IVF, or that would be the best next step before doing IVF. That might be a little bit of a harder conversation, especially if they're referred to me for that very reason, right? Like, why did my doctor refer me to you if you don't do weight loss and they told me to lose weight? A lot of people do come around to it when they understand, because so many people in all body sizes, but especially those in larger bodies, have dieted in the past, right? They have tried to lose weight in the past. So when I start to use some of the language in intuitive eating or some like allude to some of the principles in it around like rejecting diet culture and making peace with food, it resonates with them. I wanted to bring this up a little bit later. If you've heard of like the Last Supper effect, right? If you're about to embark on a diet that you might eat all the things because diet starts tomorrow, that kind of effect. And it's almost like reinforcing of why that person thinks they need to diet, because then they feel really out of control around those foods, when really it's just that anticipation of restriction that is causing this binge or this like overeating.
I think of that as my last day of vacation diet. Like, because usually on vacation, I'm like, and then it's like, oh, I got to go back to normal life tomorrow. I'd better have have that glass of wine extra tonight. It's like tomorrow I got
back to normal life.
I get that. It's that sense of like, oh, I'm going back to normal, so I better live it up right now.
Right. Instead of, my approach is more of like finding balance. So what does balance look like? What are you doing the majority of the time? Because habits over time are what make a difference on your health, right? Not having an extra glass of wine one night on vacation or having a hamburger once a month, whatever, fill in the blank fast food. Those aren't going to ruin your fertility or your health. It's what you're doing over time. So again, that approach of nourishment, of letting go of restriction and finding balance, and what balance looks like for you. Because I think the whole like everything in moderation makes sense, but it doesn't make, like, people don't understand what that means. And like, how do they put that into practice for them? What does moderation look like for them? And that's where that individualized approach comes in.
Yeah, and everybody's definition of moderation is different, and it probably changes between the foods too. Yep. So like, what's the moderation for that glass of wine? What's the moderation for chocolate cake? What's the moderation for, hamburger or whatever, or like fast food? It's going to be different for everything, because you have different thoughts and ideas and background and cultural things when it comes to that.
All those external rules that are floating around that have shaped your, right? That's what intuitive eating is really. I don't want to say a backlash, that's not the right word, but it's kind of pushing against those external rules and really being able to tune into what your body needs, because there's so many diets. And again, the 4-letter word diet, right? Of like, eat this, not that. And this is going to harm your fertility. And this is going to be great for your fertility. You should only eat this. And then we come to me with all of these rules, and it's just mentally exhausting.
Oh, totally. Usually the diets are like, they counteract each other.
Yeah. You mean like conflicting the diets themselves?
Yeah.
Right? Like keto versus vegan, often very different extremes.
Yeah.
Exactly. And actually, that's a good transition to some of the most common popular diets out there. Keto is a big one that we still are seeing. I have a lot of patients, especially my wellness patients, that have at least tried keto or currently on keto or ask me about keto. And then I have had some questions about intermittent fasting, especially with those PCOS patients, because they're starting to see that out there. So
what do you say if someone comes to you and they're like, so I've heard about keto. What do you think? Is that a good way?
I would never recommend keto, but if somebody has done keto in the past or is currently doing keto, I want to understand why. And if they've done it in the past and have stopped, I also want to understand why with that, right? When I'm digging into anyone's dieting history, I want to understand why they did that diet, any benefits that they may have gotten from it. Like some people have done, say, Whole30, which I know is a different diet, but they're like, I cooked more at home, right? That's a positive that comes out of it, even if I disagree with the overall diet itself. That's not really evidence-based.
Let's do a breakdown. Like, what does keto mean? What does it mean to be going on keto?
The word low carbohydrate, like I had a prospective client reached out about like doing low carbohydrate. And I was like, well, what do you mean by low carbohydrate? Because that can range a lot, like less than 40% of your overall dietary intake can be low carb, which is still a good amount of carbohydrates, versus keto, which the traditional keto is 5% or less of carbohydrates. It's a very, very small amount. It's a very high fat, moderate protein, low carb diet. So sometimes people, I'm like, are you actually keto or are you just very low carb? And just seeing like how that will work for them, how it's not working for them. We don't have research on keto for people undergoing IVF. And only studies I can think of with like PCOS, the attrition rate was super high, the dropout rate, because people just like couldn't do it. So you can't make really good conclusions from a study that includes 5 people.
Mm-hmm.
Right.
Like research studies usually want to have them longer term, larger amounts of people to make some conclusions and provide evidence-informed or evidence-based care from. And then there's keto, like how are you doing the keto? So there's research around keto being harmful in the preconception period, for example, as an increasing risk of gestational diabetes. And one study found that, like a review of the literature found that animal-based diet had higher association with gestational diabetes developing when it was done in the periconceptual period, preconception. And when people did a keto that was, or a very low carb, it actually wasn't keto, it was long story, but it wasn't keto specifically, it just said low carb, but plant-based, it did not have that increase in gestational diabetes risk. So I think you also have to understand the quality of the foods that you're eating.
It's so easy, at least with all the things people post, to be like keto with like, oh, look at all the bacon and the eggs and this and that. And in my mind, it's like, wow, how do you even do a plant-based, aiming for keto? Like, what are you even eating? So you have to be a lot more intentional about seeking out those other protein sources.
Yeah. And again, it was under a review study around keto diets, but it specifically called it low carb. And I couldn't access the full article to see how much that percentage of the diet was carbohydrate. But there's a big difference between, eating avocados and nuts as like this main fat and as well as fiber source, and eating bacon wrapped cheeseburger.
All the bacon.
Right.
Yeah.
Especially for cholesterol levels. Again, like I would want to meet someone where they're at, like, does it make sense? Also, in my experience working with people who are trying to conceive, I think about next phase, right? Like, okay, the intention of this is to get pregnant. Are you going to plan to continue keto during pregnancy? And every single person I've ever had an intro call with or a session with says no. So I'm like, what does that look like then? Are you going to feel bad about eating carbohydrates when you're pregnant? I can tell you from personal and professional experience, the majority of folks crave what in their first trimester?
Only carbs.
Lots and lots of just plain carbohydrates, crackers, pretzels, toast.
Everything else makes you want to vomit.
Everything else makes you want to vomit. So I'm like, how are you going to continue that? And then if you're going to gain even more weight in that period of time, because you've shifted swung so much in a different direction with your diet, then what's that mental and physical effect going to be? You can tell I definitely sway against keto, but I'm also like, do you see that working for you long term?
Yeah. And I'm thinking too, because traditionally, when you do prenatal appointments, they traditionally have weighed you at every visit. And there's like the trend that they're looking at. And I could see if you have been doing keto beforehand, and then you do have this added kind of weight gain from then coming off in pregnancy, then is your OB also reinforcing like, hey, you're having too much weight gain for this amount of time, not realizing that we're also compensating for that previous period.
Exactly.
Mm-hmm.
And then the mental stress that person's going to take on around that. There's so much shame and blame around weight. And a lot of times the people who are doing keto, it's because of weight. I've never had a client where they're doing it because of diabetes. Not to say that it isn't done for that reason, but like in my experience with the clientele that I'm working with, it's never been for that. It's been for weight loss. So I have some thoughts about it.
Yeah, me too.
I hope I shared them well.
Yes. One other thing I think about, especially for keto, which is that very, very, very low carb, and the Whole30, which is similar but not quite the same, and even like Atkins, or way back when the HCG diet,
and South Beach, all these original,
and South Beach, all the things.
It's dizzying to keep up with them.
It really is. And I kind of like to look at like what's in common with them compared to like the Mediterranean diet or whole food plant-based diet or vegan diets. And usually there's a pretty good overlap for the things that we know are good for us.
Beans and lentils.
Yeah. Whole foods, right?
Whole grains.
Yeah. Whole plant foods and avoiding processed foods seems to be ubiquitous throughout all of those.
Yeah. I mean, I do find that for a lot of folks, like they want to know that I'm going to meet them where they are at, right? A lot of them are busy working professionals. Some of them already have children, and the realities of somebody that's going to be like okay, you can only eat whole foods is not realistic for them, right? So I'm like, I'll always meet you where you're at. It's still better to eat bag chopped broccoli and pre-made hummus if that means you're going to eat it than just thinking you have to buy everything at the farmer's market and make every single thing from scratch, because
I want you to make your own pasta.
Yeah. It just, I think the word processed foods gets used in a negative way when I think we should spin that a little bit, like ultra processed things that are like super separated from what their original food was, compared to like processing like peanut butter or almond butter or pasta.
Well, I think there's a difference between like prepared foods and processed foods. Like I see like things that are just helping me with my meal prep because they're already all chopped up or they're already portioned out, or just makes it so easy to have the hummus in the little containers. Like I know I can make my own hummus with my Vitamix on the weekends, but I don't always do that. So.
Yeah, that's such a good point though, because yes, when I say processed food, I'm thinking about that ultra processed. The stuff's like
with the expiration date 3 years from now.
It never expires.
Yeah. Yes. So like eat foods that are plants, but don't eat foods that were made in a plant kind of thing. Like a factory is kind of what I'm thinking about. But those things that are like pre-made, all about that. I'm a busy professional too. I get it.
Right. I mean, like jarred beans, they're processed, right? They're not dried. They're jarred and already, been soaked and cooked and all that. So
yeah, I got to tell you, I do default to the can, or I have mine come in boxes, but
boxes,
the box of cans of beans, because I don't have time to soak.
It's affordable, it's easy to use. And if you are trying to increase plant-based proteins or legumes, like a lot of times I'm trying to encourage folks to increase them. And I deal with IBS, so I can't do a whole bunch of only beans and lentils, but like, how can we incorporate them into your diet a bit? Like, can we add a can of rinse drain lentils to your ground turkey and make tacos that way? So you're getting in those antioxidants, you're getting in the fiber, the plant-based proteins, and just shifting a little bit that way without it being like, this black and white all or nothing, which people often feel.
And what's your kind of stock speech when it comes to intermittent fasting? What do you say when people ask you about that?
Someone did ask me about that last week. I don't know of any research studies that have looked again at people undergoing fertility treatments doing that. I just think around the realities of doing that, the time restriction, does that work for your lifestyle? Are you going to show up to this meal starving and then eat to your uncomfortable? Eat until you're uncomfortable is one issue, or like eat even if you're not hungry because your window is closing. It kind of goes back to that like Last Supper idea, or like the points in Weight Watchers, like I'm not hungry, but I still have some points left, so I'm just going to eat, and vice versa. Like, I'm out of points, but I'm hungry, and we just ignore that. Like, I have issues with those, like those very externally driven rules. Now, it's a lot easier to follow rules, but that's why I'm here, right? To help people to implement that and hopefully have lifelong benefit from that, not just for their fertility period, but for pregnancy and beyond.
I know. I've just realized we bring on a dietitian who follows a non-diet approach to quiz you about diets.
Yeah.
But I feel like that's probably what you're dealing with patients,
exactly.
though, right? I mean, most people they've been reading things online. That's what they want to know about.
And look, I was trained in a very weight normative, weight centric approach. I'm a child of the 80s and 90s.
You had the Snackwell's cookies too, where they're low
we
fat.
Had Snackwell's and reduced fat peanut butter.
That's so funny because I was thinking about this episode getting ready this morning. I was like, oh, I want to bring up Snackwell cookies because I totally remember those. Yeah. And like everyone's like, oh, this is so great. You can eat cookies and they're low fat and they're like, they're not going to cause weight gain. And I'm like,
they didn't taste very good, but you were like, well, it's still a cookie, so I guess I'll eat it.
Well, now you just have like the keto bombs instead, right? We swung from like fear of fat to fear of carbs. And I'm like, where's the middle ground there? We need all the macros. Our bodies thrive off of all the macros. And it's just about like, maybe you need to shift how much you have of certain things depending on your diet. Like a vegan diet is definitely going to be more heavy in carbohydrates because a lot of the protein sources also have carbs, but it doesn't make them bad, right? And I'm putting air quotes, even though you can't see me because we're on a podcast. Right. You can hear the waving of my fingers.
You can hear it in your voice. You got that.
So yeah, even though I provide a non-diet approach, I'm very aware of all the different diets. Maybe not every single diet. That would be impossible, I think, to know them in and out. But, I'm aware of them. And because so many of my clients have dieted, like I said, we dig into like what worked and what didn't.
I really like that approach because for most things, I mean, the whole problem with diets is they're unsustainable, right? But usually you do find something out of it that you're like, actually, I did like that. Like getting up and drinking that like 3 glasses of water in the morning. I'm like, oh my gosh, I really am dehydrated. So there's always probably something that was good out of the experience. And maybe you build on that to have a more healthy relationship with food in general.
Right. Because I don't want people to feel shame that they've dieted, right? That's what we've been told is what we're supposed to do. Again, especially if you're in the certain BMI categories, right? Lose weight, eat less, move more. And I'm like, it's just not helpful and could be harmful advice. So yeah, I like for people to just not come from, I'm not here to shame or judge. Like, people also do some food journaling. You asked that before, do I have people do food journals? So I don't require it for our work together, but in the beginning, through this platform that I use, this EMR that's virtual, people can document their food intake without tracking any macros, any calories, like literally just take pictures of your food. And that gives me a sense of patterns, habits, helps that client start to understand areas they may want to improve on or have questions about or struggles and concerns.
I know with our wellness appointments, we ask for kind of a week intake, and I find most people aren't eating enough. I mean, that's the thing. Like a lot of our patients, especially our PCOS, they skip breakfast, they're having...
And they bookended.
Yeah, it's bookended, and often like the snacks are very low cal. I mean, so a lot of it is trying to explain to people that actually I probably want you to eat more than what you're eating right now. And like, let's talk about that. And I think people, especially if they've been following restrictive approaches for so long, I mean, I think it is useful to at least kind of see what is a normal daily like for you.
Right. When you're so disconnected from your intuitive eating, like hunger and fullness cues and what you want to eat versus what you should eat. Again, air quotes.
Yes. That actually brings up a good thing that I hear a lot is like, oh, well, calories in, calories out. It's just such a, like you said, nutrition is not black and white like that. If that was as easy as it was, like it's a little bit more complex than that.
It is. It's so much more complex than that. Like genetics, environment, and like we haven't even addressed social determinants of health, right? If that's even accessible to them. They have safe places to exercise. Do they have easy access to food that they have time to prepare? Are they working shifts and that's affecting their metabolic factors, let alone their time and to cook and feed themselves. There's much to it besides just like calories in, calories out.
It's a bit tangential. It reminds me a little bit of like the gun control debate. It's like, but if having more guns made us safer, like America should be like the safest country in the world. Like if information about diets was helping us eat healthier, we would be. And instead we're like the worst on all of these outcomes when you look at like all the things that we really are trying to talk about, which is what are your longer term health complications? We are not faring well compared to other countries, despite all of our very popular diet trends.
Air quote, wellness trends.
Since you deal so much in fertility, like with specific diagnosis, are there certain approaches that are better? Like if someone is dealing with, you mentioned IBS, like there's so much overlap with endometriosis and IBS. So like when you hear someone has a specific diagnosis, does that make you talk more about a specific approach for nutrition?
A lot of it does kind of boil down to a lot of the same patterns showing up in various diets, but we might have to tweak things a little bit. Like endometriosis, I'm thinking a lot about inflammation and how we can try to lower inflammation in the diet from like increasing fruits and vegetables, but maybe being mindful of the types of fruits and vegetables if they also experience IBS-like symptoms, or if they have concurrent irritable bowel syndrome on top of it, where we might be adjusting the FODMAPs. Definitely talk to a dietitian about that. Do not try to do it on your own. Do not self-diagnose that. Thinking about really inflammation and how to, again, maybe put some of the pro-fertility diet type, the research studies that we do have correlating if this person undergoing endometriosis is also going through ART, correlating improved outcomes of implantation, clinical pregnancy, and live birth, some of the facets of the pro-fertility diet, but also maybe looking at like, how is your body doing with dairy? Are you okay with that? Are you not? Like, how does it feel for you? And maybe doing some eliminations or challenges. For some folks, they've restricted so much. I'm usually trying to get them to add things in, like, do you have an issue with dairy? Do you have an issue with lactose? Do you have an issue with wheat, or do you have an issue with the fructan? And how can we challenge those? So again, we can liberalize the diet. You can have more choices. But yeah, with the endometriosis, I mean, we don't have a lot of great literature out there for it, unfortunately, but there's also some supplements that can be helpful. I really try to be food first as much as possible, but there's just some things that are either hard to get enough from in the diet or just that you can benefit from that higher dose of.
What about PCOS?
When I think PCOS, I think of inositols, right? And the benefit that they can have in menstrual regularity and insulin resistance, because PCOS can often have coincident insulin resistance. So with those folks, and again, this kind of carries through a lot of my clients, I'm looking through regular meal and snack times, right? That they're not skipping meals because, again, you could have a big blood sugar spike if you're not eating, I'm starving, grab a handful of, tortilla chips because that's all I have time for. And then a meal later, right? That's not really great for keeping blood sugar stable throughout the day. It's really looking at higher fiber and protein and fat to keep the blood sugar stable. So a lot of it is like meal patterns, like what's going on your plate or on your snack, what are you combining together? And then the frequency or the cadence of what you're eating. Like you don't have to eat at the exact same time, but I probably want you eating every 3 to 4 hours so that you're getting enough in throughout the day.
I make fun of my husband because he doesn't get up like earlier than me. He goes to work later, but he has lunch at 11 o'clock every day. And like if he ever like is in a meeting and he's like not eating by 11:30, he's like so hungry. It's mealtime. It's 11. So he's like our dog got a very firm meal schedule.
My stepdad does that too. He's like he's a very firm breakfast, lunch, and dinner,
Yeah.
and we tease him about it.
Yeah, and I'm usually advocating for an afternoon snack for almost everybody, right? Because if you're eating lunch at 12, for example, and you're eating dinner at 6 or 7, that's 6 or 7 hours without eating. Generally, blood sugar starts to drop after 4, especially like I really try to get people not to go more than 5 hours without eating. So maybe just like an apple and peanut butter or, some carrots and almonds. Like it can be just some combination of fat, protein, and carbohydrates is what I'm usually, trying to get folks to do so that they can arrive at dinner not ravenous. And maybe you need crackers and carrots and some almonds. Like you might need a little bit more depending on your activity level, your hunger level, what you ate earlier and later. There's a lot of variables there, but I'm definitely pro afternoon snack.
What about like diminished ovarian reserve or lower egg supply? Because there's so much info on that about like, I was told I had a low AMH, but then I fixed it through whatever. So like, what do you tell people when they've been concerned? And because it's such a hard diagnosis. No one expects to be told they have low reserve, especially if they take good care of themselves.
Or I have very few eggs left. I want them to be the best quality that they possibly can be.
Yeah. So with DOR, diminished ovarian reserve, I don't think there's been a lot of great research, but I did see, I think earlier this year, there was an article that came out and I took some like stats down from it. But a lot of this stuff, unfortunately, is association, right? People who do X are associated with improved outcomes, whereas we don't have great interventional studies. So there's definitely some limitations here. Same with like endometriosis, like we associate higher intake of red meat with the onset of endometriosis. But if someone currently has endometriosis, will reducing red meat intake improve that? We don't really have that information. We can glean that may have a benefit, right? And like if that makes sense for them, is accessible to them, then we try that. But I just want to kind of give that caveat that that's a lot of the challenge of nutrition studies. But anyway, they found that the pro-fertility diet, do you want to talk about that for a second? Or do you want me to just kind of give the stats?
Yes. And before we dive into the research, I'll just give that caveat that we have when we've discussed research in the past, that research is not super inclusive when it comes to gender. They really are just female, male when they talk about subjects in their studies. And then the other thing to note too is oftentimes in studies, there is language that can be seen as stigmatizing, like obesity, overweight, things like that. So if we're mentioning that, we're talking about it in relationship to the studies specifically.
I appreciate that because I think it's important to note there's limitations in nutrition research studies, just the way that we can do that kind of research compared to like double-blind randomized placebo control that you could do with a medication. You can't really do that in nutrition research. So there's always going to be some limitations from the quote gold standard, but that doesn't mean it's bad evidence. That's like we're kind of working within those constraints. But then there's also issues around gender inclusivity or weight inclusivity or the lack thereof in research studies too that we have to be mindful of, or who they're doing the studies on. Like, can we extrapolate this group of primarily Caucasian women and apply it to people who may be Black or Latina or, identify as another ethnicity? I don't know if we can always do that across the board either. So again, limitations, and that's why the importance of kind of individualizing care and working with where that person is. So pro-fertility diet was a study, I think this came out in 2019 from the Earth Research Group, that was a prospective cohort following people undergoing ART. And basically what I like about this research study was it culminated previous research studies that's been correlating certain foods or certain supplements with improved ART outcomes. And it also compared it to other healthy eating patterns, like I believe Mediterranean, the Healthy Eating Index, and I'm blanking on the one other that was compared to. But I like that it was comparing like healthy diets to other healthy diets versus like fast food diet versus this diet. Well, likely we are going to see a pretty big difference. So anyway, the pro-fertility diet included higher intake of whole grains, soy, which is another myth buster,
Yes.
food that comes up a lot, dairy products, fish and seafood, low pesticide residue produce, and supplemental folic acid, B12, and vitamin D, and higher amounts than are typically recommended to supplement with for just general health or preconception health. The research on the pro-fertility diet showed that they had higher rates of implantation, clinical pregnancy, and live birth. And then in this other study from this year that looked at diminished ovarian reserve, found that dietary patterns were not associated with ovarian reserve in quote normal weight, so BMI less than 25, and that increased adherence to that pro-fertility diet that I just discussed in people with ovaries, but specifically study with women with BMI greater than 25 was associated with significantly higher AMH, that anti-Mullerian hormone, which if you all want to explain what that is to the listeners.
They can go back and listen to one of our earlier snack episodes on Ovarian Reserve.
And I believe that was snack number 1.
It was early.
Maybe, yeah. I think we did start with, everything starts with the egg, right? So we started with egg supply.
Yeah, the OG snack episode.
But yeah, basically most correlated with the number of eggs that can be retrieved as part of assisted technology. So it's not telling you chance of getting pregnant. It's not telling you the quality of your eggs, but just, where your AMH is, especially relative to your age, gives us an idea how many eggs we think you could get your body to grow if you were either doing IVF or trying to freeze your eggs.
Thank you, Anne. So what they found was that increased adherence to this pro-fertility diet in women with BMI greater than 25 had significantly higher AMH, and those in the highest quartiles, so like even more closely, we're following a pro-fertility diet, mean AMH concentrations of 1.45 and 1.67 respectively than those in the lowest quartile. So those numbers might just sound like gibberish to people listening who are not in the medical world, but it's basically just showing this significantly higher AMH value. And then highest adherence to this pro-fertility diet was also associated with higher antral follicle count in women with a BMI greater than 25. So that's one study. And we know that the pro-fertility diet has some good evidence behind it and is oftentimes things that I might be working clients towards.
And it sounds good. I mean, it's so much overlap with all the things that we've been saying in other things too. So
I think that the outliers in the pro-fertility that can sometimes throw people from like a quote unquote healthy diet, right? Because like there's just so much definition around what that is, are the dairy, the soy, and the low pesticide residue produce, right? Because like dairy has not consistently been shown to be harmful and in fact may be helpful for fertility folks undergoing fertility treatments. Although, again, if someone's vegan, I'm not gonna be like, you have to have dairy. Like that's not my approach. It's more like, okay, if you consume it, let's try having it 2 times a day in this amount or in this context of this meal, like yogurt and granola or something and fruit. And then the soy piece, right? Because soy, everyone's like, oh, phytoestrogens, that's going to be really bad for your fertility.
Especially when I'm talking to people about their sperm, I get that a lot. Like, well, how much tofu is too much tofu, or how many soybeans can I have?
It becomes a lot. Like you have to eat a lot. So yeah, I encourage people to eat edamame and tofu, soy milk if they like it.
And soy milk tends to have more protein than like almond milk does. So.
And that's a great point. I mean, people are like, they don't want to do dairy or soy, and then they just do like almond or oat, which are fine. Like I do drink oat milk sometimes or almond milk sometimes, but they're not good like analogs.
Does make a great cappuccino.
Milk makes a fantastic cappuccino. Yes, that is my preferred for cappuccinos. But, in terms of being an analog for dairy milk, in terms of fat, protein, and carbohydrate, soy milk is a much better alternative. And again, various research studies, including this pro-fertility diet, have not shown that it's harmful. And another research study showed that it could be protective against the negative effects of BPA, right? The endocrine disruptor in plastics. So I'm pro soy.
Yeah, me too.
You need a little t-shirt.
Team carb, team soy.
Leo's for soy.
Yeah.
Oh, so team carb. And speaking of carbs too, I feel like fruit gets a bad rap.
Yeah.
I actually came up with another client earlier this week. It's like, you have to eat a lot of fruit to have too much fruit. I don't think people are getting diabetes by just eating.
Exactly.
Fruit.
That's what I've said that to people before. I'm like, if you ate only apples, I don't think you get diabetes. Yeah. I mean, you might get some other things because you need more balance than that, but
various nutrient deficiencies and other issues. But I mean, I will encourage, like, if someone's having it as a snack and it is a substantial time between meals, I will encourage them to like have an apple with the nut butter, right? Or have grapes and cheese, or grapes and also nuts, pistachios, cashews, whatever, but just something that will give it a little bit more staying power. But you get fiber and antioxidants, which is really good for fertility and glucose levels and such.
So just in general, you are pro-food and anti-diet, and you take a personalized approach. That's perfect.
Yeah, that's what really, I'm gonna write that down. I'm like, oh, you remember that. Pro-food, anti-diet, and personalized approach. Yeah.
That's really what's most important. That's what we really advocate for on this podcast too, is personalized whole person wellness. And no two people are alike. So no two nutrition plans are probably going to be alike, because we all have our cultural backgrounds and our preferences, nutritional issues and concerns and histories.
Like there are themes that tend to carry throughout my clients, right? With nutritional adequacy, making sure they're eating enough, making sure they're eating often enough, what's going on their plate, the combination of foods and certain types of foods, like the things that are included in the pro-fertility diet, especially, or other studies that include efficient seafood, whole grains, soy, some supplementation. But yeah, everyone is a little bit different, or everyone's kind of coming to the table or coming to my appointments with different histories and different current lifestyles. And so we can really tailor to them.
Well, yeah, you glossed over it briefly, but all the social determinant stuff. If someone doesn't have access to fresh produce, can you just have frozen vegetables, frozen fruits, like what cans?
Organic is another.
So there's so much to take into account in terms of what is someone's day-to-day life like, what are the resources they have in their current situation, and how can you work with that to find an approach that's going to be the best for them?
Absolutely. Yeah, I think there's a lot of fear-mongering or like classism within food.
Mm-hmm.
Sure. That you have to eat this way. And it's like, okay, only the people that can afford all of this are the healthy ones that can get pregnant from IVF. And I completely disagree with that. And yeah, you can definitely do frozen, canned. I don't think you need to do organic all the time. Even with the data on low pesticide residue produce, it's not saying that it's harmful to eat conventional produce. It's just saying that very high intake of pesticides may have some negative effects because of it being an endocrine disruptor.
For sure. Yeah. All right, Rachelle. So where can we find you?
Yeah, so the best place to go is my website. It's rachelmallik.com, RACHELLEMALLIK. Little symmetrical double L in both names. So rachelmallik.com, people can book a discovery call or intro call if they want to chat more about working together, or actually schedule the initial consultation and assessment. If you're not based in the Illinois area and you want to make sure I can work with you, definitely email me through my website or schedule that intro call. And then I'm also working on a fertility course that should be coming towards the end of the year. That will be available on my website.
And is that aimed at patients or health professionals or both? Or
great question. Honestly, it could be for both, because it's meant to be just like good quality content overviewing like the basics of nutrition for fertility, like short, easy to consume, good quality information that will have some individualized going into more detail, maybe around PCOS and endometriosis and certain conditions. Not meant to replace one-on-one, but really for folks that may not need one-on-one or want to just have like a good foundation and then may work, one-on-one with a dietitian, whether it's me or someone else. And then also healthcare providers, right? Because I know dietitians that have some clients who may be undergoing fertility treatments, but are not fertility dietitians, but they're working with them. They might want that as a resource too.
And Instagram, it's Rachelle Mallik, just your full name, right?
Mm-hmm.
And are you on the Twitter?
I am. I think I'm at Rachelle Mallik on Twitter, Facebook, and Instagram.
Well, thank you so much. I try to hold myself back because I get very excited about these topics. Try not to take over the conversation. But it's so lovely talking with you. So thank you for being with us.
Thank you for having me. It was great.
Just some references, because this is such a great topic and we have touched on several things in previous episodes. So one that's really good if you want to know more about the Health at Every Size, or HAES, that is Judy Simon's episode, and that is snack number 13. Her full episode is episode number 7.
And that's where we got into disordered eating.
Yeah. And weight loss meds, we just recently had our episode on weight loss medication where we talk about the studies that have talked about whether or not weight loss medications are helpful for PCOS. And then snack number 34 is the episode on the endometriosis study and nutrition that's going on right now at Physician Committee for Responsible Medicine.
And listen to our snack this week, because we're going to talk even more about weight loss and whether it's really something you need to be trying to do before fertility treatment, and why does it still get offered. And yeah, it was hard to not ask more about it now, but I want it to be in the snack. So
I know.
Yeah. Looking forward to talking more about that.
Yes.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review the Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.